All right. Thank you very much, Nicole. All right. Let's get. So as she said, my name is Dr. Mathew. Thank you guys for joining us for this. Today we're going to be talking about Sideline Orthopedic Management. So it is the beginning of the academic year. And so just kind of doing a quick run through some of the easy orthopedic management, going over some things we can do to prepare for the season and for the upcoming different sports seasons will be good. So I have no financial disclosures. So this is a Sports Medicine and Orthopedic Institute lectureship series. It's actually our first lecture in this series. And so we're really excited to start off with this. Our goal is to have basically quarterly lectures. The audience will be primarily athletic trainers, physical therapists, sports medicine physicians. There will be some CME credit that will be available. And we'll also be able to do some on-demand availability that should be available in the next couple of days or weeks. And so we'll give you some information about that, and we're really excited. And then as far as the topics goes, we've done a couple of polls to see what topics would be useful to people, to different people in the audience. And so if there is a topic that you think would be useful, please let us know, either JD or myself or one of our other organizers, and then we can help plan lectures that would be useful for those involved. So I think Dr. St. James already kind of introduced me. I'm Dr. Mathew. I'm down at Baylor Scott and White. My main office is in Waxahachie. We're also in Midlothian, down in the southern metroplex of DFW. I did my training here locally at UT Southwestern for orthopedic residency. I went up to New York to do an adult sports medicine fellowship, and then I went up to Boston to do a pediatric sports medicine fellowship at Harvard and at Boston Children's. So I've been fortunate to have some really good training. I've also had an awesome privilege to work with a lot of professional teams and different big events that just have been a lot of fun to cover. And even more fun, as I've started practice, I've had the privilege of covering a lot of our local schools and colleges. So it's just been an honor to take care of a lot of the athletes and work with a lot of the trainers here. Today, we're going to quickly go over some emergencies, things to watch out for, things to prepare for, some of the non-musculoskeletal injuries, and then we'll go over to the orthopedic side, which obviously I'm a little bit more comfortable and familiar with, but we'll kind of run through everything to kind of give a good overview. So ideally, this would be kind of the focus of our sports medicine management. The athlete is kind of in the center of the care. We have physicians, we have therapists, we have the athletic trainers, the coaches. There's EMS that are on staff at different events. There are parents. As you get up into the college level and professional level, you start having other managers and other people involved. So there's a lot of people involved, and the athlete is kind of at the center of all that as far as sports medicine care. In reality, really the trainer is kind of in the middle as far as how they respond to the athletes. Obviously, we're still cared and concerned about the athlete, but the athletic trainer plays a very pivotal role in really kind of being the go-to person between the coaches, between the athlete and the physician, the therapist, the parents. Really, they're our eyes in the schools and on the field. A lot of times in practice, we're not there. They're the ones describing the mechanism of injury. They're the ones relaying that to parents, getting information, discussing therapy, treatments, options. So really, they're kind of the crucial part of this is the athletic trainer. And so I'm very appreciative to all the trainers that we get to work with around here. They're fantastic. And so I know they're really the unsung heroes in this sports medicine kind of care and management team. And so my appreciation to all of them. So first of all, just talking about emergencies. And so, the first thing we always say is always have an emergency action plan and make sure everyone on the team knows what that plan is and how that plan functions. It's really kind of difficult, especially at the beginning of this year, and particularly because last year was so different for a lot of schools. A lot of different teams and seasons were changed around, so it really wasn't a normal year by any means last year. And so coming into this year, there's been a lot of new changes as far as staff goes on the athletic training staff, new physicians, new students who may not have experiences last year. And so it's really important that everyone on the team knows what the plans are for certain events or catastrophes, and really knowing where all the equipment is. I can't stress the importance of that enough. And really that comes down to practice. As a resident here in the DFW area at Parkland Hospital, we saw a lot of crazy trauma come in. And one of our attending surgeons always told us, hey, when an emergency happens and someone comes in, their legs hanging on by a thread, everyone comes into that ER trauma bay and everyone's panicking. Everyone's looking at you for that stability. So as the training staff, if a patient or an athlete gets hurt on the field, there's a lot of people looking. There's a whole crowd of people that might be up there during a game. There's coaches, there's other players. So everyone's heart rates are beating. And so the more you can practice a plan, the easier it is to effectively be able to go through that plan when an emergency does happen. So I would highly advise that the whole team, including the training staff, the student trainers, a lot of schools have PRN trainers that may not know how things work at different schools, or they might be kind of plug and play for different events. So it's really important they know where all the equipment is, whether that's a spine board, the AED, EpiPens, knowing what the system for transport is. Is there EMS available at this event? Do we need to call someone? What's the time frame on getting someone from the hospital or to the hospital? And so having a plan for all that really makes everything go a lot more smoothly. And so, as Michael Scott would say, failing to plan is planning to fail. And so we really want to do everything we can to be successful and hopefully plan for things that never happen. So that, the ABCs for emergencies, we start off with airway and cervical spine protection. This is really important. Obviously, you want to protect their airway. If they're unconscious or you're uncertain about their cervical spine status, it's always better to be safe than sorry and practice cervical spine precautions. That's something that's not really natural to most people. So that is definitely one thing I would work with on your team, perhaps before the season starts or right at the beginning of the season, especially for your major contact sports like football, hockey. Getting in and off the ice can be difficult, or getting on and off the field, but making sure that everyone on the team knows their role and knows how to do it. Breathing, circulation, making sure that they have good pulses, disability, neurologic status, doing a quick neuro exam, and then also exposure and environmental, making sure that the athlete is no longer in danger. So if there's anything that's endangering them, whether that's weather, other equipment, other people, that all those things are safely secured. So, obviously I'm more orthopedic related, and most of those things are not life-threatening. The things that are life-threatening are your cardiopulmonary events. So one thing that I would make sure that everyone knows where the AED is. Every AED is a little different. They're pretty similar, but making sure that you have it, the batteries are charged, that you have extra pads and leads to put on them. Like I said, schools that have plug-in PRN trainers, making sure that they know where it is. Usually at a football game, you have one out there and everyone knows where it is. But sometimes if you have softball practice, baseball practice, multiple events going on in different places, people may not know where that AED is, but it's very important that everyone, especially on the training staff, the students, whoever can come grab it, basically should be able to know where it is, and so they can quickly get it. So we're not losing time trying to get it, or if the battery's not charged or things like that. So checking on those things is very important. For our spine injuries, making sure that there's a spine board available, whether the EMS is bringing it or there's one on in the facility somewhere, knowing where it is so that someone can quickly grab it is also important. Here in Texas, we don't really have to deal with cold injuries too often. Obviously, we do have a lot of heat-related injuries. So depending on what the event is, if it's a cross-country meet or having an ice bath, having other equipment, thermometers, knowing where and how to use the thermometers, all those things are important. It sounds silly, but if you don't plan for it, especially some of the student trainers or other people that might be helping out on big events, they may not know what the protocol is. So making sure that you go through that. Open fractures, obviously that can also be alarming to some people when they see bone poking out of someone's skin. And so knowing where to get some irrigation, having a traction splint, something that you can put on, stabilize the fracture and get the patient to EMS. Luckily, big events, hopefully you do have EMS there. That's a little easier. They have some of that equipment and ability to do those things as well. Continue with emergencies. So really neurologic injuries, in addition to the cardiopulmonary, those are really probably some of the most important things that you should be planned and prepared for, because those can be the most devastating. You've heard about epidural, bleeding events, hemorrhaging events. So an epidural hematoma has a very classic lucid interval where the patient does okay for a few minutes and then they slowly start deteriorating. So that's something to keep an eye on. So if someone does have an injury and you're concerned, it's easy to kind of have them come to the sideline, check on them 1 minute and then walk off and not keep someone on them, but maybe having a student trainer or someone else or an assistant trainer over there kind of keeping an eye on them, keeping them, talking to them, or at least making sure someone's watching them as they go over the next 5, 10, 15, 20 minutes, or even an hour after their initial injury is important. A subdural hematoma, it's a lot less common, however, a lot more lethal. Really accounts for almost 80% of traumatic brain injury deaths in sports. So these are things you want to keep an eye on when you have a neurologic injury. You want to get a full neurologic exam, including an eye exam. You want to have a flashlight or a pen light to be able to do a pupillary reflex. You want to monitor the vitals with blood pressures. Most people have the kind of pulse oximeters that you can put on their fingers that are battery powered. So those are things to have around that would be useful. And also, like we said before, you want to maintain C-spine precautions, especially if the patient is unconscious. I would treat the patient as a C-spine injury until proven otherwise. So make sure you do all those things. And these can be a lot of different moving parts. And we want to make sure that we're able to do that in a timeful fashion. So the red flag symptoms is something that I always say, especially with concussions. I know concussions have gotten a lot of attention and publicity over the last several years, and rightfully so. But things that kind of differentiate a concussion from maybe something a little bit more severe. So in my book, if a patient has a severe headache or a worsening headache, if they're extremely drowsy or unable to recognize people or places, in the fact that they're becoming disoriented, if they have significant nausea, vomiting, or seizures, if they start developing weakness and numbness, a little different than a stinger where they have that and it gets better, this is where they start getting worsening weakness or numbness. If they have slurred speech or unsteady gait, all of those things are red flag symptoms in my book of keeping a very close eye and having a very low threshold of getting this patient over to EMS or over to the hospital for a more full examination. Some of the other non-orthopedic injuries, so ocular injuries, this can go anywhere from an abrasion, superficial abrasion, to a globe rupture. So, you want to make sure you get a good exam on them. You want to get a good visual acuity exam. If you have a Snellen card, that's helpful. If you don't, you can use your fingers and be able to kind of get a gross exam on them. You want to check the pupillary exam as well, looking at the reflexes. As far as dental goes, really for most of your contact sports, you want to make sure your athletes are using mouth guards. You can really prevent so many dental and oral facial injuries by wearing mouth guards. So just really stressing the importance of that to your athletes, to your coaches. I think most institutions and other athletic organizations really mandate those. the high risk sports. And so that's really important. Really, if you have a small laceration, or if you have an infraction or just a crack on the tooth, I think you're able to return back to play pretty safely. If you have luxation or avulsion of a tooth, pretty much any other major dental injury, the athlete will be out of play for that day. You want to make sure that you have, if you do have a tooth avulsion, that you have something to put it in. Some people have the Hank's balanced salt solution. If you don't have that, most people have either milk or saline around. Those are both acceptable things, or saliva. And then if you don't have any of those other things, you can always put it in water. But that is a dental emergency to be taken care of. Musculoskeletal injuries, and this can vary anywhere from abrasions, hematomas, all the way up to dislocations, and then also fractures. And then kind of the worst case scenario would be open fractures. So those are all different types of injuries that you can have. Dislocations in particular are about 5% of all sports injuries. The most common one, hands down, would be a shoulder dislocation. Wrist, hand, and finger is kind of a distant second, with knee most of the time being a patellofemoral dislocation, also kind of being a close third. Anytime you have a dislocation, the first thing you want to do is check their neurovascular status. So you want to make sure that all of their sensory and motor nerves distal to the joint that's been dislocated is working. You want to make sure that they have good blood flow. So good check on the upper extremity, radial pulses. Make sure they have good cap refill to the fingers. On the feet, you want to check a DP and PT pulses. Make sure it's nice and palpable. And then you want to also see, do they have sensation? Is their motor intact? Obviously, if they've dislocated their ankle, it's a little difficult to move things, but you can kind of get a gross idea of what their neurovascular status is. But really, really important that you get that prior to doing any kind of reduction, prior to doing any procedure. You got to check that off the bat. And then as far as reduction goes, it's a little bit of a controversial topic. Who should do the reduction? What reduction should be done? So I'm going to give kind of a broad overview of what I think would be appropriate for people at the right levels of training. This is by no means a black or white kind of thing. There are some trainers who have a lot more experience than probably even myself doing a lot of these reductions on the field. And then there's some that have no experience. And so really it's up to the trainers on the field, the physicians on the field. There are certain injuries I think you should avoid trying to do reductions, or at least be aware of some of the consequences. So the good thing about, there's advantages and disadvantages to doing reductions on the field or in the locker room. And so some of the advantages are obviously the patient or the athlete will be in less pain. The longer time that the joint is dislocated, you're going to have some of the muscles that will start to spasm. So not only will that make it more painful for the athlete, but it'll also make the reduction more difficult, just because their muscles have spasmed and tightened down. So if you're able to do it immediately, you're able to do it a little easier. At the same time, and then the other obviously advantage in some of these injuries, you might be able to reduce them and then get them back into the game, depending on what the situation is. So that's a possibility. So those are all the advantages of being able to do a reduction. As far as the disadvantages, and you got to be aware of it. If you're going to do a procedure like a reduction, there are disadvantages involved. One of the risks associated with that is further neurovascular injury. So someone may, and that's why you want to check before you do a reduction to make sure that they're neurovascularly intact. Once you reduce them, it is possible that you could injure one of the vessels or nerves that go to that arm or leg. So it's possible you could cause further injury to their nerves or vessels. Especially for some of our younger patients who have open growth plates, they're a little bit of a higher risk for when you try to reduce them. You actually might cause a fracture in itself across the growth plate. Those who have fracture dislocations and the fracture is minimally displaced, if you try to reduce it blind, that means without x-rays, it's possible that you could displace the fracture. So as I said before, there are risks and benefits to doing a reduction on the field without having any imaging to go off of. So you have to be aware of those. You have to be careful. And like I said, I think there are certain ones that really should be done either in the emergency room with some imaging or in an office or with the physician. I think there are a lot of ones that the trainers should be able to do or can do on the sideline, depending on their comfort level and their support that's around them. As far as return to play, it really depends on each injury, and we'll kind of quickly go through some of these things. So like we said before, the most common dislocation that you probably see is shoulder dislocation. These come in a lot of different varieties. The first thing you really want to be able to elicit is what type of dislocation is this, or what type of patient is this, in the sense that, is this something that happened for the first time, or has this patient had 20 dislocations before and they've actually been able to pop it back in place themselves? That really does change how you manage this. And so that a piece of history is very important to find out once this happens. There are different types of dislocations. In general, when you describe dislocations, you describe the position of the distal part of the anatomy in relation to the proximal part of the anatomy, and we'll go over that here in a few minutes. As far as reduction attempts go, my kind of general rule of thumb for shoulders, for kneecaps, for some of the more simple dislocations is that I would try to do it on the field once. If you're not able to do that on the court, if you're not able to be successful at that point, I would take the patient or athlete into the locker room. I think a second attempt is worth doing. And if at that point you're not able to do it, I really would not do more than 2 or 3 attempts. The problem is, at that point, if you're really having difficulty doing it, A, it's very painful for the athlete. B, it's possible that they have a fracture or a fracture dislocation, which at that point you really could make it worse. Or C, the joint has gotten lodged somewhere that's really hard to get out of. So one place, sometimes like for a glenohumeral or shoulder dislocation, the humerus can get lodged underneath the coracoid and get stuck there. And so you can get trapped underneath the biceps tendon. So sometimes if it's stuck, you're going to cause more damage if you keep trying to do reductions. X-rays, if there's one thing that I can really drive home today, is that I would have a really, really low threshold for getting X-rays. I can't tell you the amount of times that I've seen athletes, 1 to 2 or 3 months out from their injury, never had X-rays, and then they have a fracture or injury that would have been very easy to take care of and probably without surgery off the bat, and then it turns into a very complicated surgery. So if, like I said, if there's one thing I kind of drive home today, is I would have a very low threshold for getting X-rays. Obviously, if you reduce a shoulder on the field, most high schools and even colleges at this point don't have X-rays in their stadiums or locker rooms. And so you may not be able to get that till after play. I think it's okay to go back to play in certain situations and get X-rays afterwards. And we'll go over some of that. As far as shoulder dislocations go, like we said, there's different ways that it can dislocate different locations. By far, the most common would be an anterior dislocation. That's about 95% of the time. That really comes from someone being in that abducted external rotation position, quarterbacks with their arm getting ready to throw, football players going in for a tackle, basketball players going up for a layup. So that's the kind of most common mechanism of injury for them. When you see them on exam, you'll see that they'll have a loss of their shoulder contours, especially compared to their other side. For some of our bigger athletes, it's a little difficult to assess that, but for some of the skinnier ones, and the ones with less muscle, you might be able to kind of notice that. You'll feel some anterior or inferior fullness due to the humeral head being located there. And usually the patient will come in with their arm abducted just a little bit and possibly either internally or externally rotated just a little bit. And obviously their motion will be significantly limited secondary to pain. Posterior dislocations, much less common in our athlete population. The ones you do see this is when someone falls on their outstretched arm. Sometimes offensive linemen who are going up for a block have their arm in that adducted internal rotated position, and that can drive the humerus back posteriorly. Once again, you'll see a loss of contour, decreased range of motion, pain. And then the least common one that you'll probably see is an inferior one, or what we call luxation erecta. Really, I've only seen 1 or 2 in my career. They are very rare. And when you see it, you won't forget, because you basically will have the patient come in with their hand or their forearm kind of over their head, and they can't bring it down. I even heard stories of people having to go to be driven to the hospital with their arm out the window because they couldn't get their arm down. So it is rare, but if it happens, it'll be very easy to notice. This is an X-ray of that same position of a inferior dislocation. As far as shoulder dislocation reduction, there's different types of reduction maneuvers that can be done. Probably the most common one is what we call a traction counter traction. So basically an assistant or a second person has a towel or a sheet wrapped around the patient's body. You have them supine on the ground. You're pulling axial traction through the patient's elbow, flexed at about 90 degrees. As you're pulling axial or longitudinal traction, you should feel the humerus kind of pop into place. And so I would say it's probably the most common method that I see people or that I try doing directly on the field or in the locker room. On the locker room, it's easier because you can put them on an exam table and do that. Or if you have one on the sideline, you can do that there. Once again, having that second person is very helpful. You can even use your one hand to pull and the second hand to kind of help direct the humeral head back into place. This is a similar kind of maneuver, what we call the Milch maneuver. Once again, you have the arm at 90 degrees. You can also use a second person to help pull from the other side. The difference on this one, you're going to really use your right hand or your dominant hand to feel the humeral head and help it kind of glide it back into place to where it belongs. The Stimson maneuver, this is less useful in the sideline or on the field. This is one that I do use in the emergency room sometimes, or even in the office if someone comes in. Once their muscles have spasm, this helps kind of reduce that. So I think I've done this one time for someone who's in practice. They came back to the locker room. We kind of let them hang for a few minutes. But basically, you tie 5 to 10 pounds off the patient's arm. They're laying in the supine position, and slowly that weight will kind of break the tension or the spasming of the muscles and allow the shoulder to reduce. And it'll reduce without the patient even knowing. So, as far as returning back to play, so once again, it really depends on the patient's injury and their kind of history. If patients who had this happen for the first time, it's pretty unlikely that they'll be able to go back and play. It is a pretty painful injury. They're going to have a lot of swelling. It's going to be inflamed. Normally, you're going to be out for somewhere between 4 to 6 weeks after a acute primary shoulder dislocation. Obviously, that can be a little different for each athlete, but that's kind of the norm. As far as chronic dislocators, they might be able to pop it in themselves and go right back in. So my kind of criteria of them getting back to play is basically, do they have full pain control, or do they have pain that's controlled and full range of motion, as well as neurovascularly intact distally to their hand. So if all those criteria are met, I think it's reasonable for the patient to be able to go back. I do like using a Sully brace. I think for different certain positions and sports that can tolerate it, I think it is helpful. It does provide some feedback for the patients to reduce the risk of a re-dislocation. And then, like I said, once the patient has gone back to play or not gone back to play, once again, it's really important we get an X-ray. If someone has a shoulder dislocation in the middle of a season, I try to treat it conservatively, at least through the season, and then we at least have a discussion whether about fixing it after the season. However, if they do have a large bony Bankart fracture or some other cartilage lesion on their MRI or X-ray, we may consider doing surgery sooner. So it is important to get imaging, especially on an acute or traumatic shoulder dislocation. Working our way down to the elbow. The elbow dislocations are relatively common, and they get more common in our younger patient population. So middle school and even elementary school kids, it's much more common. Usually they're falling onto their flexed elbow, and the elbow dislocates either posteriorly or posterior lateral almost all the time for athletic injuries. These are ones that we do want to try to reduce on the field or in the locker room, and then get them into a splint. They normally cannot return back to play immediately that day after this type of injury. Usually 1 to 3 weeks is how long it takes, depending on what all they've injured. There is a high rate of concomitant fractures. And so the way that we try to reduce it is basically trying to pull distally with some longitudinal traction before you put the elbow into flexion. If You can see here, if you just straight try to flex it, you will probably break this coronoid portion of the ulna if it's not already fractured. So you don't want to just go ahead and flex it. You really want to pull that longitudinal traction to get that edge of the coronoid over the humerus so that you don't fracture it. So it's really important for that reduction maneuver. Like I said, this is another one I would definitely get x-rays. You may even need to get a CT scan or MRI because you can have small fractures of the coronoid process. You can have a tear of the UCL ligament. And so these are ones, depending on what all is injured, kind of determines how soon they can get back to play. Hand and finger dislocations, most commonly is the fourth and fifth fingers at the CMC joint. This is common for people if they're punching someone or if they're blocking someone or they land onto their clenched fist. You can see this. You'll have a lot of swelling in the hand. Once again, this is one that I would have a very low threshold to get an x-ray if they have a lot of swelling in the hand. About 70% of these get missed, including a bunch that even have x-rays. You can have a very subtle fracture or a very subtle subluxation or even dislocation, and it get missed in the ER, get missed in the urgent care. So it's very important that you have someone that's musculoskeletally trained look at this, as well as making sure that you do get imaging. If you have to have this fixed, the return to play is about 2 to 3 months. For hand dislocations, the most common one that I'm sure all of you have seen at this point is dislocations of the proximal IP joint, the PIP joint. This can dislocate in different directions. And so the treatment kind of depends on which way it dislocates. It can be dorsal, lateral, volar. Usually the mechanism of injury for this is hyperextension with an axial load. So someone going up for a block, someone getting their finger caught in someone's pads. Most commonly happens in the fifth finger and then even the fourth finger. They're the ones that this usually happens to. Usually you can reduce this on the field. You can buddy tape or splint it appropriately and then get them back to playing that same day if their pain is controlled. Once again, this is one, even if you get them back to playing and it looks reduced, you make sure you want to get x-rays. I can't tell you, probably once or twice a week, I have kids who come in who tell me that they can't bend their finger. This one and the fracture we talked about earlier, the CMC dislocations, these can be chronic problems down the road. If you don't get them fixed, patients end up having limited range of motion, chronic pain, and decreased grip strength. So if this is your dominant hand or even your non-dominant hand, that can be quite a problem, even not just for sports, but for writing, for doing things with their jobs. So, you don't want your athletes to have chronic issues like this. So getting x-rays is crucially important. You can see on the bottom here, sometimes you have this type of dorsal dislocation, but you've also got this fracture here. So it's a fracture dislocation. And these are ones, depending on the size of fracture, you may want to fix, or you can treat without surgery, but you want to be able to catch this on the front end. Otherwise, you might buy yourself a surgery for the athlete. So the reduction technique for these fingers, if they have a dorsal dislocation, you want to hyperextend and so kind of recreate the injury, provide axial traction, and then flex. And that should reduce the digit. If they're laterally dislocated, same thing, you want to do axial traction, so pulling longitudinally, and then reducing it in the opposite direction that it dislocated. With volar dislocations of the IP joint, this is really important. You want to make sure that you first keep the finger flexed, then provide axial traction, and then extension. If you try just to pull it straight into extension because it looks flexed, you're going to have a hard time extending it, and you can actually cause further injury. It's kind of like a Chinese finger trap with the ligaments that will be intact. So if you just try to extend it, you're going to have a hard time reducing it and may cause further injury. So as far as splinting goes, you do splint these differently. If you have a volar dislocation, you want to splint those in full extension at the IP joint and DIP joint. If you have a dorsal or lateral dislocation, you want to splint them in about 20 or 30 degrees of flexion, and that will allow the volar plate to heal in, because a lot of times the volar plate, which is located on the volar aspect of the fingers, will be disrupted with those dorsal and lateral subluxations. If you're not sure, it's always best to, like I said, have this patient come in to see us or see a hand surgeon and make sure that they're taken care of appropriately. Going down to the lower extremity, hip dislocations, these are pretty rare, but however, they are very devastating when they do happen. This is one that requires urgent evaluation and management. This is one I probably would allow the team physician, if they're available, to try on the field. Otherwise, probably get them over to the hospital or emergency room. Likely they'll need some sedation or pain medication, and we definitely want to make sure we get x-rays. There is a time component to this. The longer that the hip is dislocated, the longer chance you have for having some really bad outcomes as far as avascular necrosis or cutting off the blood supply to the femoral head. So there's a time component to this. This is one that an emergency that needs to go to the hospital. When you get to the patient, usually you'll see that their limb is a little bit shortened. There'll be inflection, internal rotation, and adduction. Once again, you can also see that with a hip fracture, which is less common. A lot of times with these hip dislocations, you will have a fracture of the back part of the acetabulum or the socket side of the hip. When they dislocate, especially in these traumatic athletes, they knock off a piece of bone off the backside. So once again, this is one that I probably, if I was, I would allow the team physician to try if they feel comfortable. If they don't, this is one that I would get over to the hospital kind of as soon as possible. Knee dislocations, the true knee dislocations are a lot less common than a patellofemoral dislocation. And so this is a tibiofemoral dislocation. So the femur and tibia have moved into different places. By definition, you've at least torn two, most of the time 3 or 4 ligaments of the knee in order for this to happen. Sometimes they can have this injury and it self-reduces by the time that a physician or trainer gets to them. So you want to do a good exam and make sure you didn't miss this. These can be devastating injuries because there is a high chance of a neurovascular injury. So your popliteal artery and vessels go right behind the back part of the femur. So you can see, and it's kind of tethered to the tibia. So when you have this type of dislocation, you can completely shear some of those vessels. So it's really important that you get a neurovascular injury immediately. If the physicians are there, or if you guys want to do an ABI Doppler exam, if you can't get pulses. Once again, these are emergencies that need to get to the hospital kind of as soon as possible. You do want to do a kind of immediate reduction because especially if they don't have pulses, if you reduce them, it's likely that if the vessels are just being kinked off, that they can be have flow get back to them. And so you want to reduce it as soon as possible, get the leg out to length, put them in a mobilizer, and then get them over to the hospital or talk to your team physician about it. Like I said, these can be very devastating injuries, especially if there's a neurovascular component to the injury. This x-ray right here is one of our college football running backs who this happened to on the field. We got him reduced. He underwent a stage surgery for ACL, PCL, medial collateral ligament, and posterior lateral corner with both medial and lateral meniscal repairs. He's about 15 months out from his initial injury and is able to get back to football this fall. So he had a very good outcome. But once again, this can be a very devastating injury. So it's very important. This is one that I would recommend trying to reduce on the field if you can. If you try once or twice and you cannot, then I would immediately try to get him over to the hospital. Sometimes some of the soft tissues can get stuck in the way and prevent you from having a reduction. The reduction maneuver is really just longitudinal traction, so pulling on the tibia and then trying to reduce the tibia back either anterior, posterior, or medial or lateral, depending on where it is. Patellofemoral or kneecap dislocations, this is much more common. This is probably one of the more common things that you will see. Very similar to a shoulder. You're going to have to get a good history on the patient. Some kids will have chronic kneecap dislocations. If that's the case, sometimes they might be able to reduce it themselves, or it's reduced before you even get to them. Most of the time, the mechanism of injury for this is usually a twisting injury as they're coming down from a jump or twisting to turn or pivot. Sometimes you can get a direct blow from a helmet or another athlete. That's less common, but it does happen. And almost always the kneecap goes laterally. It's uncommon for an athletic injury to cause a medial dislocation. The reduction maneuver, this is one that I would also try to reduce. The reduction maneuver for this is pretty simple. You just get the knee into full extension, and that should kind of pop it over. If not, you can give a gentle kind of force to the kneecap, and it should kind of slide or pop over. For patients who've had this happen to, either from a twisting injury or they're having this happen chronically, there's usually an anatomic component to it. Either their kneecap rides a little high, what we call patella alta, or they have a very shallow groove that the kneecap sits into, or their kneecap itself is shaped very flat so that it can dislocate easier, or that their tibial tubercle is very laterally located so that their whole vector force of their kneecap is going out. And you'll see some of those kids who are very knock-kneed who have this. So having said that, it really depends on what's the mechanism of their injury. When you are able to reduce it, you want to put, if this is one that's a chronic dislocator, some of those will reduce and be able to go back to play. The ones that happen to acutely for the first time, usually it's about 4 to 6 weeks before they're able to come back. We put them through therapy, icing, anti-inflammatories, all those kind of things. You want to be careful when you do reduce it. Most of the times when patients have or athletes have damage to the cartilage, it's usually from the reduction, when it either self-reduces or someone reduces it. That's when the cartilage kind of shears off the bottom side of the patella. So you want to be very careful and gentle when you do that if you do a reduction. Dislocations of the foot and ankle. This is also kind of more common in our volleyball and basketball players when people are coming down from jumping at a height. It's usually from a twisting injury or falling from a height. Most of the time you get a subtalar dislocation that goes medially, and then every once in a while you can have it go lateral as well. On exam, you'll see a very obvious hindfoot deformity. Sometimes these can be difficult to tell a difference between this or a true ankle fracture dislocation. Regardless, you kind of treat them both the same way. If you're going to reduce it, I would put longitudinal traction through the hindfoot, through the heel, and then try to basically line the foot back up under the tibia. If you're not able to do this, sometimes some of the soft tissues can get interposed. Once again, you want to check a good neurovascular structure anytime that you have one of these injuries, and then also get a good exam on them before. And if you do try to reduce them, try to get a good exam on them afterwards. If you do get them reduced, put them into a splint, and then we'll have them come to the ER or office to get x-rays and CT scan. These have a very high rate of concomitant fractures. About 50% of the time we'll also have some type of fracture. So we most likely will get some advanced imaging as well. The return to play, if they have no fracture whatsoever, it's probably still looking at 10 to 12 weeks. If they have fractures, it can be even longer. So it really depends on the injury. This is what an x-ray for that subtalar dislocation looks like. And so you can see it's subtalar because unlike an ankle fracture where you dislocate here, this is actually below the talus, where you can see the whole midfoot has been taken off laterally. So that's kind of just a quick overview of a lot of the common injuries that you might see, common things that you can do for reductions. I'm just to open this time up for any questions that people might have.
Okay, I don't see any questions for the Q&As. So if anyone who is listening in has any, if you want to type those in, or you can unmute and send those out.
Well, once again, thank you guys for all of your time. I know you guys are very busy, especially in the mornings, heading to practice. Hopefully, if other people want to watch this, we can get the link to them. Thank you to JD and Dr. St. James for helping set this up. It takes a lot of work to set up these kind of things, so I really appreciate all of their help as well. Good luck to everyone as the seasons get going. If there's any questions or if there's anything that we can do to help, please let us know. I think the next lecture, our kind of goal is to do one on a concussion, kind of up to date on concussion management, and that will be done by Dr. Trin, who's our concussion specialist. So thank you once again for your time.
Thank you, Dr. Mathew, for joining us. It was a great lecture, and I think it's going to be very useful for all of our athletic trainers. I will be posting this to our upload channel, and I will send out links to that for those of you that would want to access for this later on. All right.